My name is CRogers. I'm a senior in the Department of Biomedical Engineering. I work under Dr. Peter Fino in the Neuromechanics and Applied Locomotion Lab. What we are addressing with our research is balance recovery as a part of improving clinical concussion protocol. My name is CRogers. I am a senior in the Department of Biomedical Engineering here at University of Utah. And in my time since being here, I've worked under Dr. Peter Fino in the Neuromechanics and Applied Locomotion Lab. And what we are addressing with our research is introducing balance recovery in order to improve clinical concussion protocol. Problem we are addressing here is that this current concussion protocol does not mimic the demands of the real world. About 1.5 million Americans sustain a concussion each year, with symptoms of that injury being headache, dizziness, fatigue, lack of concentration, slower reaction time, and balance deficits. And while some of these symptoms resolve in a few days or weeks, which is known as the acute injury phase, there are some deficits, particularly those having to do with balance, that persist for years after one is deemed clinically recovered. Currently, balance is assessed in static conditions in a clinical setting, and these static balance tests have been shown to lack the sensitivity to these subtle balance deficits that are persisting years post-concussion. And despite complex locomotion being very common in daily life, it's rarely assessed post-concussion. For example, we perform around 800 to 1,000 turns per day, which comprises 35 to 45% of the steps we take. We also have to avoid obstacles that are presented to us by uneven surfaces. For example, if I am trying to get into my kitchen here, denoted by the star, I would have to perform multiple turns and even avoid my roommate's shoes that she left in the way. And both of these actions challenge both dynamic and reactive balance control as opposed to only static balance control. And these dynamic and reactive components are more challenging in that your base of support and your center of mass are moving, as well as, again, that chance that you would have to respond to these unexpected stimuli. So what we are trying to do with our protocol then is to combine these more challenging dynamic and reactive aspects of balance control that we can then add on to the current static balance assessments that are currently being utilized in clinical settings. Again, our aim here is then to better mimic the real world and implement this protocol in that clinical setting to better diagnose concussions. And we do that by quantifying the response to underfoot perturbations while subjects perform dynamic turning tasks. Specifically, how this response might change with expected postural disturbances, as well as turning versus straight line walking, and then varying the walking speed. And in order to deliver these postural disturbances or perturbations while one is walking, we have these mechanized custom designed shoes based on the design previously published by Kim et al. You can see here on the left picture that the shoes look rather normal, and that is how the subject will begin a 3-minute walking trial. But every so often, an arm will deploy for one step. You can see in that green circle there. This is known as the perturbed step. And the steps following then are the recovery steps. You can see here an earlier rendition of our shoes, and there is no arm prior to this step that the subject takes. But during this mid-swing, that arm deploys, the subject steps on it for that perturbed step, and then the following steps, the arm retracts for the recovery. What we found with our straight line protocol was that anticipatory adjustments um, caused a difference in response in healthy and controlled individuals. With the unexpected perturbations, there are no anticipatory adjustments. There's only that proprioceptive feedback from that block and the subject stepping on it. But like I said, we have that expected condition in which a audible beep is delivered one step prior to the perturbation step. So this warning essentially allows the subject to make these anticipatory adjustments based on the memory of that proprioceptive feedback from those previous perturbations in the trial. With turning, however, we do see anticipatory adjustments, but now it's in the form of leaning into the turn to establish that new equilibrium or base of support, especially at faster speeds. So what we expect to see here then in a turning setting is that this perturbation response should be exacerbated with additional anticipatory adjustments. And by that, I mean that audible beep and that leaning into the turn. How we collect this data then is we have our subjects perform continuous turning tasks where they walk around a slightly raised circular path in either the clockwise or counterclockwise direction at various speeds and with unexpected and expected perturbations. And while they're performing all of these different trial conditions, they're wearing inertial motor sensors that you can see here, indicated in the regions on the figure with these squares. Now, what we expect to see with turning are centripetal acceleration vectors that like so. So for example, if one was walking around a turn at a normal speed, you can see that these vectors on the inside foot are shorter than those on the outside foot. Again, this is due to that subject leaning into the turn. The magnitude of these vectors, however, changes with walking speed. When we increase walking speed, we expect the vectors to look more like these blue vectors here, where the left and right feet, or the inside and outside feet, are both still pointing toward that center with that leaning, though they are more equal in magnitude. We also expect, based on previous research, that the direction of these vectors will change with the concussion, and they may look more like these black vectors. You can see here where they point towards the subject's center of mass as the subject is leaning less into the turn once they have sustained a concussion. Now, this is important to remember because in our studies, due to study limitations, only the left foot is being perturbed. So we would expect to see differences in terms of direction based on where that left or those red feet are. And our preliminary results show a response in that clockwise direction. And this is when that left perturbed foot is on the outside. And you can see here the angular velocity plotted against the centripetal acceleration vectors for the unexpected perturbation conditions on both the right and the left feet. And again, these are concentrated into two groups because of that clockwise and counterclockwise direction. Now, the blue indicates all of the steps during the normal unperturbed trials. The red indicates all of the steps from the perturbed trial, while these black ones on the left foot here indicate the perturbation steps on the left foot, and then the black ones on the right foot indicate that first recovery step. So we look at the perturbation and the recovery steps to see how the subject responds. And with the unexpected condition, we really only see a slight increase in centripetal acceleration. Though with the expected condition, we see more of a response, both on the perturbed step in the clockwise direction and on the recovery step in the clockwise direction. Now, as you could see on the previous slides, we only have one subject's worth of data to look at in this manner. So the first step in the future then is to collect about 10 to 15 different subjects, healthy subjects, in order to establish response patterns that we see in healthy individuals, which we can then compare to that concussion population. And those differences we observe between the healthy and concussed patients could be due to those balance deficits from their injury. Excuse me. We can then look at altering the perturbation conditions to see whether or not they elicit a different response. This might include increasing the walking speed, causing an inversion perturbation versus the eversions that we are currently delivering, as well as delivering these perturbations to both feet. And one key aspect we'd like to observe in the future with both healthy and concussed individuals is whether or not they adapt to these perturbations throughout the trial. Again, we are performing all of this research in hopes that incorporating multiple domains of balance control, so that would be static, dynamic, and reactive balance control, can help improve the clinical assessment of concussions. And with that, I'd like to thank you all for listening, as well as my PI, Dr. Peter Fino, and my grad student mentors, Nick Creeder and Carter Liebert, as well as the funding I've received from Interdisciplinary Engineering and Europe.